Chapter 25 covers bleeding and shock. As review the main components of the cardiovascular system: the heart, the big pumping of the fluid, transporting the blood through the blood vessels, and the blood itself. Arteries carry the oxygenated rich blood away from the heart. They're comprised of big, thick, muscular walls, so they're able to self-constrict and dilate depending on what the demands of the body are. Capillaries are the microscopic ends of those blood vessels. That's the exchange site of where the oxygen and all the gas exchange happens at the cellular level. Veins are carrying the oxygen depleted back towards the heart. I know that they're not oxygen, they're only oxygen depleted. There's still oxygen in there, just not as much as the arteries. The remaining oxygen of what was used at the capillary level, at the cellular level, is what is left in there. The veins will have one-way valves to prevent any backflow of that blood throughout the body, so it doesn't start going the wrong way and pulling backwards in events such as a bad heart pump or something along those lines. Main functions of the blood is to transport gases, nutrition, and excretion of all this bad stuff out of the body, as well as protection and regulation. Perfusion is defined as the adequate amount of blood circulation throughout the body. That means that blood is getting to all the places it should be in the body. If there's hypoperfusion, that means there's inadequate perfusion of blood throughout the body. So essentially, shock is just hypoperfusion. Now we'll talk about bleeding. Just basic couple types of bleeding: internal and external. Hemorrhage is referred to as severe bleeding. So if a patient is hemorrhaging, they are just bleeding. Medical term for that. Generally, the hemorrhage, that is the number one reason for shock or hypoperfusion in patients, generally related to just trauma. So 3 types of external bleeding. Arterial bleeding is spurting bright red blood, generally pulsating with the body. So you'd see it be squirting out and squirting out and squirting out. It'll be coming out continually. It's just whenever the heart contracts, it'll squirt it out further. Venous bleeding is just more of a steady flow, caused from typical lacerations. Capillary bleeding, kind of the slow oozing blood from, say, a road rash, something along those lines. So kind of in most serious: arterial bleed, life-threatening. Capillary bleeding, generally covered up with a Band-Aid, will be okay. External bleeding is bleeding you see on the outside. The person is going to continue to bleed based on a couple variables. Number one, size and severity of the wound. Did they get stabbed by a small splinter and they're barely bleeding, or did they get shot by a high caliber rifle? Depending on where they've hit in the body, if they've affected any organs, if they hit any major vessels, or if they've only cut small vessels. So you can imagine, if you cut the tip of your finger, is a lot less blood than if you cut up, say, around your bicep very deep. Just depending on anatomically where that injury occurs is depending on what kind of vessels it will attack and how bad the bleeding may be, and that person's individual ability to clot, whether they have any underlying medical issues or if they're taking any blood thinners. Remember, patient bleeding, asking for blood thinners is a very important question to ask. Again, arterial bleeding, bright red blood, squirting without a heartbeat, the oxygen-rich blood leaving the body. So just think about that the blood leaving out of the arterial bleed is oxygen rich. So the oxygen needs to be getting to the cells, isn't because it's squirting on the ground. These will be by far the most difficult to control based on the large amount of blood, and they're going to be slippery and hard to apply pressure, put on a tourniquet. They will, being a high pressure vessel, will take a lot of pressure to control, and sometimes it's in an area to where you can't apply a tourniquet. The venous bleeding is generally darker in color and a little bit slower. It's not always life-threatening, but it very well can be. Capillary bleeding, generally never life-threatening, but it can be if it doesn't ever get stopped. There have been patients who've died from nosebleeds, which are generally just capillary bleeding, but they've bled for hours and days. Along with underlying health issues and patients being on different types of medications that may impair blood clotting, also hypothermia affects the ability to clot. So if stuff is really cold, it's not going to be able to coagulate well at all. So thinking about some things, how bad is the bleeding? Is it an exsanguinating hemorrhage? Meaning, is this bleeding they're going to die from? So if so, how does that affect the treatment? So what do you think? If you see exsanguinating bleeding, how does that change your treatment? Do you still worry about the airway and your breathing before you control that life-threatening bleeding? So assessing of that patient, control bleeding only after assessing and treating other elements, unless it is that exsanguinating bleeding, unless you believe that person is going to die if you don't stop their bleeding immediately. Be cognitive of the signs and symptoms of shock, which we'll talk about a little bit later, and use direct pressure, elevation, hemostatic agents, and or tourniquet to control the bleeding, in that order. Direct pressure, first and foremost, always. So applying that direct pressure, use firm, hard pressure applied to the wound, using a gloved hand and some kind of gauze bandaging or some kind of device that's going to cover it up, and you're not looking to absorb the blood, but you're wanting something that will kind of absorb the blood and give it surface area for a clot to form too. So hold the pressure over it until bleeding is controlled. If need be, after you apply the bandages, if it's beginning to work, just keep pancaking on the layers until it quits saturating through all of those. And this will take a whole lot of pressure. You may have to put your entire body weight into this to get the bleeding to stop. Once that bleeding is controlled by the pressure you've caused by your hand, wrap it up in something tight. Take a cling wrap or something along those lines to keep that pressure applied. But never remove those bandages. Even if you think the bleeding stopped, don't remove that. The only person who should be removing that is somebody at the hospital, most likely the surgeon. Or the person who's going to put in stitches. If you go and remove that bandaging, it's basically just the same thing as picking a humongous scab. It will just start to bleed all over again, because the scab will and clot will form up against the bandages you have applied. So don't pull the clots out of the wound. Once you've controlled bleeding and all is taken care of, check for pulses to address the status of perfusion. Also, when you've addressed it clean, if you're doing just direct pressure, you want to make sure you still got some circulation going, unless you absolutely need to make a tourniquet. So with direct pressure, essentially you just want to create enough pressure to control the bleeding by whatever means you have to do. You're not using the bandages trying to make a tourniquet. You're there just to control the bleeding. So a lot of direct pressure over it, allow the clotting cascade to begin to happen, and slow the blood flow. You can use elevation to get that injury above the level of the heart. With that, if it gets above a heart, it's harder to pump fluid uphill, so getting that extremity up above the heart will reduce the pressure at the wound site. So that can aid in your direct pressure and aid in just controlling the bleeding in general. Now, if it's some kind of traumatic injury that is musculoskeletal in nature, or they've been stabbed, don't be elevating if it's going to make the injury any worse. Hemostatic agents were kind of originally designed for military purposes, but have come into the EMS realm. They're designed just to help whenever you're applying direct pressure. It basically absorbs that liquid and gives a different type of surface area for the clot to happen. So it will kind of pull the blood away from the skin surface, allow that clot to happen more easily. So, because if a clot's really hard to form in a big puddle of liquid, so if the liquid gets pulled away, it's easier for it to clot. These originated as powders. You've probably seen in some of the old movies they've poured gunpowder on wounds to cauterize them. Kind of the same concept. Some of these do burn a little bit, but anymore they're designed very, very well. But with these, you can't just lay them on there. You still have to use manual direct pressure. This is the most common type. Quick Clot is the brand of combat gauze. Most common type you're going to see in the pre-hospital setting. Tourniquet is used if all other means are not possible, or if it's just bleeding that you can't get to, or you know they're going to die and you know that's what you need to do first. So if you can't control direct pressure, elevation, everything else, or it's just going to be your first go-to, use a tourniquet. Use this on extremities only. If you're bleeding from the head, you don't want to put a tourniquet around somebody's neck. So put it between where the wound is and the heart. Picture of one kind of commercial tourniquet device. You see they've got direct pressure applied, putting the tourniquet on a few inches above the site, and they just crank it down. This will be a twisting mechanism. They'll twist it and lock it into place. So basically, tourniquet, they're all do the same thing, but they may be designed a little bit different. Some are twisting buckles, some are lashed. They all operate a little bit differently, so just follow that manufacturer's instructions on how to use it. But just note that a tourniquet cannot be too tight. You apply a tourniquet until you can't make it any tighter. Some papers show that you put a tourniquet on until you can't feel any distal pulses, but you put a tourniquet on absolutely as tight as you can. It will be extremely painful for the patient, so you're going to have to reassure them of that, but it is there to save their life. Once it's applied, don't remove it. The only person that's going to remove this tourniquet is somebody at the hospital. Once it's applied, some tourniquets have a little spot where you can write what time the tourniquet was applied, but otherwise, make sure you document it on a run sheet, or write it on the tourniquet, or write it on the patient's limb with a marker or on their forehead. Make sure that whenever this patient gets transferred from care to care to care, that's going to be easy to know how long that tourniquet has been in place. Controlling bleeding is undoubtedly a skill to help save lives. Again, begin with direct pressure. If that's not going to work, apply a tourniquet. Now, if you're going to get a tourniquet, most of the time it takes just a few minutes to get out of a package and get it prepped. So, in the whole time, direct pressure should be applied at some point in the process, regardless. Unless you just come beep bopping off an ambulance carrying a tourniquet in your hand to a trauma call, direct pressure is going to have to be applied, even if that means just with a hand only. Now, if it is on the trunk or the head, use hemostatic agents and bandages with direct pressure. So, evaluating your bleeding control. You gotta be thinking, is it working well? Is this direct pressure working, or is it saturating through these dressings and just running everywhere too fast? Do you need to go on or have applied the dressing? Is it slowing down now? Do you think another stack of dressings is going to make it better? Just continually evaluating that bleeding control. Other things that go along with bleeding control is splinting. If there are broken bones, there is generally going to be internal bleeding. So anytime you control bleeding in a site, you need to splint that. That way it's going to minimize movement of muscles, ligaments, vessels, everything, and go along with helping control that bleeding internally and externally. Some areas will allow you to use cold application of, once you've splinted, bandaged, done everything, you can put ice packs over top of it and constrict those blood vessels and help reduce the pain as well to control that bleeding. But all this must be done in conjunction with manual stuff. Some special situations regarding bleeding is with head injuries. There could times be blood coming out of the ears or the nose. That is bleeding you don't want to control. You just want to let that go, because that's blood coming out of the brain. If you plug that up, it's going to make the blood back up into the skull and increase cranial pressure. So in those circumstances, you need to just let that flow free. In nosebleed, basic simple bleeding control here. Have a patient lean forward. None of the old methods of tilting the head back and pinching your nose. You're going to make a patient choke on their own blood. Lean forward, apply pressure to the nose, generally the fleshy portion. Just pinching on the cartilage. Just keep them calm and just keep holding pressure. That can be caused by sometimes pressure will control that, other times it won't. Say if their blood pressure is extremely high, causing the nosebleed, that may not come down until they get the blood pressure under control. Also at times, this may require having sutures or cauterizations done on the nose to get the bleeding controlled. Don't go packing stuff up there. Some war stories of patients having tampons packed up their nose. It's not our job. Don't be stuffing things in there. Internal bleeding is caused by the organs and vessels internally. This bleeding you're not going to be able to see. So it doesn't mean that a patient's going to have internal or external bleeding. They could very well have both. This can be caused by a variety of things, such as blunt trauma, caused from falls, motor vehicle accidents, blast injuries, types of penetrating trauma such as gunshot wounds, stab wounds, impaled objects. So when you're looking for internal bleeding, you got to do very good patient assessments. So knowing where the injuries are at, also looking for bruising and swelling and pain and where exactly this may be anatomically. Also be looking for all the orifices that bleeding could be coming out. Also looking for tender, rigid, or distended abdomen. If you start to see this means that the abdominal cavity is filling up with blood and is becoming very, very hard. If they're vomiting up coffee grounds, upper GI bleeding, or it could be caused by just poor health things, but in this instance of trauma, it could be because they've had damage to their organs and it's getting into their stomach tract and they're going to start spitting it up, and the bleeding can come out of both ends. And then be looking for those signs and symptoms of shock. Here's a good picture of some bruising that's caused by internal bleeding. So for patient care, maintain those ABCs, give them high flow oxygen. Oxygen helps with the healing process of injuries. Control any of that external bleeding you may see. Take steps to preserve body temperature. Keep these patients very warm. Remember, hypothermia does not help the clotting factor. So you want these patients to stay warm, because hypothermia will just make shock go even faster. And provide prompt transport. Get them to a hospital. Shock, as I said before, is just simply hypoperfusion. Just not enough blood flow getting to all the tissues. And also with that, not a good, it's inadequately removing all the waste products from those cells. Some causes of shock from the heart. The heart can just lose its ability to pump. The vessels, they dilate, or they've, from the blood, they're losing their volume, making those blood vessels not full. So two types of shock, compensated and decompensated. Compensated means that the body still has its ability to balance itself out to try to keep everything going whenever there's hypoperfusion occurring. Decompensated means that the body has lost that ability, that it can't manage itself effectively, and it's going into decompensated shock, that the patient is starting to go down the tube. So here's a good referencing chart for the severity of shock. 4 basic phases within shock, depending on average of percentage of blood losses here for typical hemorrhagic shock. So you see your first stage of shock, pulse rate still normal, blood pressure still normal, respiratory rate normal, everything seems to be okay. Next thing you're seeing over here is you're seeing that heart rate starting to go up, but the blood pressure is still normal and respiratory rate's going up just a little bit. And then over here you're seeing the heart rate go up even more, and then the blood pressure drops. Once that blood pressure is dropped, this is decompensated shock. So you can see with this, the heart rate's up, large amounts of blood loss, the respiratory rate's going up, and their mental status is changing. They become anxious, confused, here confused, lethargic, pulse rate's super high, everything's decreasing, respiratory rate's way up. This is generally going to be irreversible stuff. Basic types of shock. Hypovolemic shock comes from a loss of volume, whether blood and or plasma. It's called hemorrhagic shock if that hypovolemia is caused by blood loss. This can also be caused by burns, crush injuries, severe dehydration, such as the elderly patient who has very bad nausea, vomiting, and diarrhea, and multiple other types of instances. Cardiogenic shock, basically the heart is just not pumping adequately. It's lost its strength of contractions. It could be caused from electrical system malfunction, making the heartbeat too slow, too fast, or being irregular, throwing that cardiac output way out. Or the patient's having a heart attack, has sustained trauma, or other things that have just damaged the heart. There's neurogenic shock, which result from uncontrolled dilation of the blood vessels because of paralysis. There's essentially no blood loss with this, but the vessels just dilate by themselves. So the containers of blood the containers of the vessels aren't full of blood anymore, so everything is hypoperfusion. But this is something that is very rarely seen. A note for pediatrics, kids will compensate very, very hard, whereas adults, you'll see their trends or their vitals trend more so, the heart rate going up, and they're compensating. And they'll compensate for a certain amount of time. You'll see them slowly start to go downhill, whereas kids, they'll compensate really, really, really hard, but whenever they get to the point where they can't compensate anymore, they crash extremely fast. So you need to readily identify any signs or symptoms into a kid that they could potentially be going into or currently in shock. So the progression of shock, you'll see possibly a change in ultramental status, have pale, cool, clammy skin, be nauseous or vomiting, and seeing those vital sign changes. The late signs in shock include thirst, pupil dilation from hypoxia, and sometimes cyanosis. Biggest care for shock, getting them to an appropriate facility, getting them someplace to have surgery. The number one way to fix shock and trauma is bright lights and cold steel of an operating room. The goal is to remain on scene for less than 10 minutes. And remember with all this stuff, transport to the closest appropriate facility. So if they need to go to someplace that they're going to need surgery, and you're in a remote area, this means you may have to call for a helicopter. Otherwise, maintain an open airway and assess respiratory rate, making sure you're checking those A's and their B's, and control their C's. Splint any suspected injury. If they're bleeding from someplace and you've controlled bleeding there, splint that also. Even if you don't bleed from broken bone, if somebody just got their arm cut really bad, after you've got the bleeding controlled, still splint that. Prevent heat loss. Get trauma patients warm. Wrap them up in several layers of blanket. It doesn't matter if it's July, keep them warm, because that blood is what keeps your body warm. So if you're starting to lose your warming fluid, they're going to be cold. The coldness will make the shock progress faster, so keep them warm. and transport immediately. Otherwise, provide them some very good comfort measures.